morning everyone. We are continuing with the Ecmo series and today is the second lecture on Ecmo complications. We are going to focus on patient related complications today. The overall incidence of patient related complications is nearly twice as that of mechanical complications. These complications are related to anticoagulation, extracorporeal circulation, cannulation and underlying clinical condition of the patient. Many of these complications also depend on the components which are used for Ecmo. For example, hemolysis is seen more with biopump and least with centrimac pump. Also, hemolysis is more if the size of cannula in tubing is inadequate for the patient. Bleeding is the most common complication which is encountered both in VA as well as VV Ecmo, which is followed by neurological complications in neonatal Ecmo and renal complications in adult Ecmo. So this is basically the patient related complications which can be seen. First is hemorrhage, which can be at the cannulation site or surgical site or GI bleed. Then hematologic complications like hemolysis or DIC. Neurologic complications which include brain death, seizures, CNS infection, CNS hemorrhage. Renal, acute kidney injury. Cardiovascular complications which are myocardial stenting, arrhythmias, tamponade. Metabolic complications like hyper or hypoglycemia, hyperbilirubinemia, metabolic acidosis, alkalosis. Pulmonary complications like pneumothorax, pulmonary hemorrhage, infection, sepsis and Ecmo dependency. So now we are going to see one by one all these complications. So first, coming to hemorrhage, bleeding is the most common complication during an Ecmo run, accounting for about 8 to 65% of cases in cardiac Ecmo and 18 to 46% in respiratory Ecmo. Bleeding is more common in adults as compared to neonates and more in cardiac than respiratory Ecmo, most probably related to overheparinization to prevent thromboembolic phenomena. Overall, the causes of bleeding on Ecmo are overheparinization, dilution of coagulation factors, consumptive coagulopathy, thrombocytopenia, and any local causes like surgical intervention or any minor trauma. Another common cause of bleeding site is intracranial bleeding, which is most commonly seen in neonates. Bleeding can lead to hypotension, anemia, hypovolemia, and local effects due to compression. Management. Temporarily, we can stop heparin and maintain ACTs around 160 to 180 seconds. Can supplement clotting factors by giving FFP, cryoprecipitate, platelets, and one should ensure that platelet count is at least more than 1 lakh per millimeter cube. If there is bleeding of unknown origin, then one should always rule out DIC. Additional drugs such as epsilon aminocaproic acid, aprotinin have been used to manage significant surgical site bleeding and complications like ICH. However, aprotinin is not used these days because of the renal complications associated with it. Other drugs like tranexamic acid and nafamostat mesylate can also be used to control bleeding. If it is very severe intractable bleeding, then recombinant factor 7A can also be used. It induces hemostasis at the site of injury independent of the presence of factor 8 or factor 9. It forms complexes with exposed tissue factor. But if recombinant factor 7A is used, one has to be ready with another primed Ecmo circuit because there are very high chances of thrombosis. Local measures are compression and purse string sutures at the cannulation site or horizontal matrix sutures to control cannulation site bleeding. If bleeding is significant, then surgical re-exploration with careful hemostasis may be required in some cases. Another option is using topical hemostatic agents like gel foam or fibrin glue. When bleeding occurs in intrathoracic, abdominal or retroperitoneal spaces, it should be effectively drained. In case if there is GI bleed, mild GI bleed usually will respond to Baumeges plus lavage, sucralfate and or H2 blockers or proton pump inhibitors. In extreme cases, octreotide 25 to 50 microgram per minute infusion can be used, and gastroscopy with sclerotherapy, glue or local adrenaline can be also used. Now coming to hematological complications, first is thrombocytopenia. It occurs due to dilution, increased consumption, sequestration of platelets to extravascular sites and decreased production secondary to hypoxia or sepsis. It is expected during Ecmo as platelets are activated and get aggregated in the Ecmo circuit. These platelets are then preferentially sequestered in lungs, liver and spleen. Thrombocytopenia can occur for up to 4 days even after termination of Ecmo. Hemolysis, it is related to Ecmo components. Broadly, the causes of hemolysis are: it is usually seen when there is increased suction effect, when the negative pressures exceed more than -20, or any obstruction in the circuit. Smaller size of cannula or cannula malposition can also give rise to hemolysis, or any clot in the circuit, especially in the oxygenator or pump. Clots in the oxygenator may promote coagulopathy by activation of complement, WBCs, platelets or coagulation factors. Excessive heat production due to loss of one of the bearings can also give rise to hemolysis. Diagnosis of hemolysis is made by presence of high colored urine, red serum, elevated LDH, serum bilirubin and retic count, and free hemoglobin increases and becomes more than 50 mg per deciliter. Severe hemolysis will lead to renal dysfunction and DIC. Treatment: if suction effect is higher at the venous end of the circuit, then one should give volume or reposition the cannula or add one more cannula for adequate drainage. If there is a visible clot in the circuit, then that part of the circuit should be changed. And secondary measures to prevent renal failure like alkaline diuresis and Lasix should be given, and urine output should be maintained in the range of 2 to 3 ml per kg per minute. Coming to disseminated intravascular coagulation, it is a very serious and dreaded complication with the incidence of 1 to 5% and is associated with very high mortality. Cause is circuit related is presence of some clot in the circuit, most commonly in the oxygenator or due to severe hemolysis. Increased blood flow rate in relation to circuit components, or patient related due to severe hypoxia, sepsis or underlying disease condition of the patient. Treatment is again treatment of the underlying condition like correction of hypoxia, hemolysis and treatment of sepsis, and one can consider supplementation of coagulation factors. Next is neurological complications. They are one of the devastating complications and most frequently leads to termination of Ecmo, for example brain death or massive ICH. Incidence is 16 to 28%. Causes of neurological complication are non-pulsatile flow, thromboembolic phenomena, use of anticoagulation, underlying patient conditions like hypoxia, hypotension, and neurological complications basically include ICH, brain death, cerebral infarction, and seizures. Neonates are more prone for neurological complications and they are more commonly seen with VA Ecmo because of the following reasons. First is the return cannula in the artery is in the artery, so there are more chances of thromboembolic phenomena, and carotid artery may be used for cannulation which might compromise the blood flow to the brain. And if the returning cannula is in the carotid, then it will give highly oxygenated blood flow to the carotids which will cause reflex cerebral vasoconstriction. Diagnosis of neurological complication can be made through neurological examination, EEG, CT or MRI. Daily neurological assessment is important to diagnose the complications earlier, and hence daily sedation break is essential. The incidence of brain death during Ecmo is reported to be 1.1 to 7%. Reasons for brain death are massive intracranial bleed, cerebral infarcts, cerebral hypoxia due to inadequate cerebral perfusion. Ecmo should be discontinued once brain death is confirmed and after discussion with the relatives. Only condition where Ecmo is to be continued despite of brain death is when the patient is potential organ donor. Another complication is seizures. Incidence is more in neonates and pediatric population as compared to adults. It is a manifestation of some neurological insult like intracranial bleed or cerebral infarct, or some metabolic cause like hypoxia, hypoglycemia or hypocalcemia. Cerebral infarction during Ecmo is usually due to thromboembolic phenomena. The incidence is more with VA Ecmo. Treatment is mainly rehabilitation, cerebral decongestant and neuroprotective agents. CNS hemorrhage, most devastating complication of Ecmo, which is seen more in neonates and pediatric population again as compared to adults. Premature infants are at greatest risk of developing ICH on Ecmo. Hypoxia, acidosis and cardiovascular instability prior to initiation of Ecmo, prematurity, coagulopathy all increase the risk of intracranial hemorrhage. As a rule, appearance of a new ICH or increase in the size of pre-existing ICH are an indication to discontinue Ecmo. Hypoxia can also directly injure the brain capillary endothelial cells and lead to significant ICH. Factors contributing to ICH in neonates are hypoxia, hypercapnia, acidosis, ischemia, hypotension, sepsis, coagulopathy, thrombocytopenia, venous hypertension, seizures, any birth trauma, rapid infusions of colloid or hypertonic solutions, systemic heparinization. Diagnosis in neonates can be made by cranial ultrasound. It should be routinely used pre-ECMO as a screen and daily for the first 5 days on ECMO in newborn. Very high incidence of ICH if infants are less than 34 weeks of gestation. Heparin, however, may not increase the risk of ICH in neonates who weigh more than 3 kg. They are maintained at lower ECT parameters, 180 to 220 seconds, with platelet counts of more than 1,25,000. Systolic hypertension must be avoided and treated rapidly, and hypoxia, hypercarbia and acidosis should be avoided. Renal complications. Transient renal dysfunction is common, especially for the first 24 to 48 hours after initiating ECMO. However, these are self-limiting and usually does not require any intervention. Cardiovascular complications. The incidence ranges from 3 to 60%. They are more common again with VA ECMO than VV ECMO because the loading conditions of heart do not significantly change with VV ECMO. Depending on the heart condition and underlying general condition of the patient, the complications vary. Patients with severe acidosis with pH of less than 7.2 show high incidence of complications as compared to patients with normal metabolic status. Hypotension is the most common complication, especially seen after initiation of ECMO. The usual cause of hypotension is decreased preload, myocardial stunning and SIRS, leading to release of chemical mediators which cause vasodilatation, increased capillary permeability and non-pulsatile flow. It usually responds to fluids and might require some inotropic support in the form of dobutamine or adrenaline. If there is systemic inflammatory response syndrome like picture, vasopressors like vasopressin or noradrenaline may be used. Arrhythmias are also commonly seen on ECMO. They occur due to electrolyte and metabolic disturbances or may be a manifestation of free perfusion. Myocardial stunning. It is a reversible condition in which LV fractional shortening decreases by more than 25% with initiation of ECMO and returns to normal after around 48 hours on ECMO. It is more commonly seen in neonates and occurs due to decreased preload, increased afterload, hypocalcemia, hypokalemia and coronary hypoperfusion. During VA ECMO, due to retrograde flow, the LV afterload increases, and if the returning cannula directs the blood flow towards the aortic cusps, it can lead to difficulty in the LV emptying. So there is decreased ejection and distension of LV. It can lead to MR, pulmonary edema and cause pulmonary hemorrhage. Failure of LV function to improve even after 4 to 5 days suggests myocarditis or infarction. Treatment of LV distension is increased preload, correct electrolyte imbalance, use of inodilators and IBP, which will increase the forward flow and decompress the LV by venting or septostomy. Tamponade. It should be recognized early. Elevation of intracardiac pressures and there is limitation of ventricular filling and decreased cardiac output. Causes are hemopericardium, hemothorax and tension pneumothorax. Here there will be decreased cardiac output and increased ECMO flow leading to narrow pulse pressure. The triad of increased PaO2, poor peripheral perfusion and decreased venous return with progressive hemodynamic deterioration is consistently associated with cardiac tamponade. Treatment is drainage of the pericardial fluid and the drain should be kept in situ till the bleeding stops. Pulmonary complications. They include pneumothorax, hemothorax and pulmonary hemorrhage. Tension, hemothorax and pneumothorax can lead to tamponade effect. Treatment is ICD insertion, and if there is hemothorax, then one should try to maintain ECT around 160 to 180 seconds. If bleeding is continuous, one should rule out DIC, supplement coagulation factors. Pulmonary hemorrhage is usually mild and stops with simple measures. Usually due to suction trauma to trachea or parenchymal bleed secondary to infection or left atrial hypertension. It can be controlled with higher PEEP, optimizing heparinization and replacement of the clotting factors. In case of severe bleeding, bronchial artery embolization might have to be done. Bronchoscopy to remove any major clots. Patients in Ecmo with sepsis usually develop other complications like seizures, GI bleed, renal dysfunction, and multi-organ failure, which increase the chance of sepsis. Usually it is associated with poor prognosis, and these patients are prone for multi-drug resistant organisms and fungal infections. Treatment is antibiotic of choice, and barrier nursing should be practiced if there is leukopenia. Thromboembolic complications, they are more seen with VA Ecmo. If there is limb ischemia, then one can do distal perfusion by inserting a distal perfusion cannula. Maintaining adequate heparinization and vigilant monitoring of the circuit to avoid any clots. In case of any clot, the ACT of 180 to 220 seconds should be maintained, and change of that particular circuit component should be considered. Embolectomy in case of limb ischemia. Metabolic complications are hyperbilirubinemia, metabolic acidosis, alkalosis, hypo or hyperglycemia. Hemolysis, TPN, diuretics, and prolonged fasting may predispose patients to development of biliary stones. Now coming to last complication, it is ECMO dependency. Usually the patient shows improvement in 8 to 10 days after institution of ECMO. Few patients, especially obese, may require a little longer duration of ECMO, even 4 to 6 weeks. If after 2 to 3 weeks there is no improvement, one should start looking for associated problems hampering the recovery. If no other factors are found, consider lung biopsy or cardiac related problems, which can be solved by catheterization or by myocardial viability testing. If there is a reversible condition, then one should wait for recovery, and if irreversible, any assist devices or transplant should be considered. Thank you.